Good morning, everybody. As always, thank you for joining. As always, giving a moment for everybody to get into the webinar today. We have a very special grand rounds today, and we have a really large group of some of our amazing team here. And I'm really excited for this, and one we've been planning for some time. We have just a few updates because we have some awards to give out as well. But I want to first turn over to Dr. Dunn for some upcoming events that she's been promoting. So Dr. Dunn, thanks for being here and for sharing updates on that. I'll turn it over to you first.
Thank you so much, Dr. Ozdalga. Well, it turns out June 9th is a big day for events for us. Next week, on Friday, June 9th, we have the Kumba Dance Troupe coming to join us and do a wonderful performance. That's going to be on the Dean's Lawn from 1 p.m. to 2 p.m. That's right in front of the Allway building, if you don't know where it is. And there's also going to be some catering by Black-owned businesses. It's going to be a really nice afternoon. So we hope you all can come and join. This is in honor of Juneteenth, which is coming up, now a federal holiday. And hopefully it will be a Stanford holiday in future years. And you can register using the QR code that you see on the screen, or they're going to be putting the link in the chat. So please come June 9th, 1 to 2 p.m. Right before that, there is going to be an anti-racist community conversation with Dr. Cornell West, who is a scholar, anti-racist, philosopher, educator, just an amazing person with social commentary that you really won't want to miss. That is happening immediately before the the drumming troupe. That's going to be on Friday, June 9th again, 11 a.m. to 1 p.m. in LKSC, and it's going to be hybrid, so there will be a Zoom option for that. The QR code is on the screen, and the link is in the chat. We hope you will be there for 3 hours of amazing programming next Friday, June 9th. Thank you so much, and I'll go back to Dr. Ozdalga.
Thank you, Dr. Dunn, as always. Hope to see you guys there. I just want to mention next week, we are celebrating Pride Month. We have Dr. Lanakai, Dr. Lanakai, who's been presenting Advancing Care for LGBTQ plus patient population. Again, as you know, June is Pride Month. We kick off the first Wednesday MGR of every June celebrating that. And of course, since the first Wednesday of the month, we will also be in person as well as on Zoom. So if you can, please do join us in person for some free coffee and breakfast and to see some people in person. So please do come if you can. If you of course can't, we'd love to see you still on Zoom as well. So looking forward to that one next week, special one next week. That being said, we, again, as I mentioned, we have a special grand rounds today. Before that, we're going to actually have some awards being shared as well. So I'm going to turn it over both to our many presenters today, as well as all our chief residents are with us today as well. So I'm going to turn up to you guys first for these awards, and thanks again for everybody being here.
Well, good morning, everyone. Thank you so much. It's an honor for my co-chiefs and me to be here to be able to listen to our wonderful grand rounds by Dr. Christine Santiago, one of our co-chiefs. Before we do that, it's our honor to be able to present the Clinical Decision-Making Award winners among our residency group. Every year, we submit a nomination form out to the program to request nominations. And this year, we were very lucky to have had many nominations. So these were the 4 winners who we're proud to be able to present today. Maria Mosvin from among the first-year class, in addition to Jack Leclerc from the second-year class, and then Gary Chen and Balu Pillai among the third-year residents. And so we'll move on to going through each of the winners and what were the cases that really stood out to us as we were reviewing the nominations. Next slide. So first was Maria. So Maria, in one of her, this was actually her first clinic day as an intern in the Stanford Internal Medicine Clinic, took care of a 60-year-old woman who came in with a constellation of multiple symptoms, including several months of lower abdominal pain, dysphagia, diarrhea, dyspnea, unintentional weight loss, and periorbital ecchymoses. And then click next. Kind of based on those symptoms and the constellation of her exam findings of anasarca, the scattered ecchymoses, including the periorbital ecchymoses, and then also her observation of the patient's hypoalbuminemia, Maria very astutely was suspicious for whether this patient could have amyloidosis. So she sent additional testing for that with SPEP, UPEP, free light chain ratio. She ordered CT, chest, abdomen, pelvis, and echo, and gave a referral to for upper GI endoscopy. And then very astutely, she correctly diagnosed this patient with AL amyloidosis with biopsy-proven GI involvement, in addition to evidence of cardiac and renal involvement. And so she picked up very quickly what could have been a diagnosis that could have gone missed for a very long time. And so we just wanted to really recognize Maria and thank her for all of her incredible work, and for proud that she was able to help diagnose this patient.
Thank you, Sarah. I have the honor of presenting our next award winner, Blue. He really was phenomenal, not just with one diagnosis, but 2 diagnoses that he made, and I will present one of them. This patient was a 70-year-old woman, was admitted for symptoms of an upper respiratory infection, malaise, and was treated for a community-acquired pneumonia. Based on minimal symptom improvement and development of an AKI, Blue raised the concern of granulomatosis with polyangiitis and ordered PR3 and MPO antibodies. The PR3 antibodies returned positive, and the patient was treated with pulse dose steroids and rituximab. Her kidney function normalized months later, and the final diagnosis was granulomatosis with polyangiitis. And so I wanted to highlight this case and Blue because I think it really stands out that Blue does not anchor on diagnoses that have been given. He keeps a broad differential, and when the patients are not improving, he really does consider other etiologies for their conditions. And one of his award nominees, his nominations said that it was so easy to fall into a pitfall of common diagnoses we encounter in clinical settings. But Blue made a huge difference in patient care by carefully observing the case and appropriately asking the most important questions, preventing readmissions by discharging this patient with a correct diagnosis and providing excellent patient care. Thank you, Blue.
All right. Next, I have the honor of introducing Jack Leclerc's case, our 3rd recipient of this award, who is a PGY2. Jack's masterful clinical decision-making was highlighted in this expert diagnosis and management of a 24-year-old gentleman with HIV. He had presented to the emergency department with agitated delirium and was admitted to the ICU with a working diagnosis of alcohol withdrawal. Jack received this patient as a downgrade to the medicine wards team for continued management of his alcohol withdrawal, thought to be alcohol withdrawal. On Jack's bedside evaluation, however, this patient was tachycardic, diaphoretic, and drooling, prompting him to obtain immediate cross-sectional imaging, which revealed acute epiglottitis. He notified ENT promptly, who quickly performed an emergency tracheostomy to stabilize this patient, who was ultimately diagnosed with acute epiglottitis. I will just say, working with Jack, Jack has demonstrated being a clinical avenger at its highest level in this, especially in this case. It's easy to fall into pattern recognition or diagnostic momentum, especially on patients who have been evaluated prior to you by our outstanding clinical care doctors, to both comprehensively and efficiently work through a differential diagnosis in a critically ill patient, cross-check clinical features, and then advocate for that speedy workup and management of a vulnerable patient is truly something to be admired. I wanted to add that he's continued to inspire clinicians who work with him, including this honorable mention by one of our pulmonary hypertension colleagues who stated in a nomination for him, "We got a new admission for an extremely sick pulmonary hypertension patient who continued to decompensate and eventually got intubated. I was very impressed with Jack's medical knowledge, his calm presence, his demeanor, his ability to know when to step up and ask for more help, his procedural skills. And though he is an early R2, he is well beyond his years in training." We really look forward to the bright future of this master clinician. Congratulations, Jack.
Our next recipient is 30-year resident Gary Chen, and future nephrologist, and he was nominated for his care of a middle-aged, otherwise healthy and previously independent woman who presented with profound weakness and inability to stand and no longer able to even stand up in the grocery store line. The patient was initially thought to have some sort of autoimmune process, inflammatory peripheral neuropathy, or subacute combined degeneration from vitamin B12 deficiency. And the person who nominated Gary was really impressed by his ability to take a step back and revisit the diagnosis when things weren't making sense. And so he noticed this patient had a persistently elevated lactate, persistent weakness despite B12 deficiency, but despite B12 supplementation. And so he effectively led a team through this complex diagnostic process, looping in multiple consultants, and eventually got involved with a biochemical lab fellow and made a diagnosis of mitochondrial myopathy. I think to make a diagnosis that's truly this rare in adult patients requires a lot of humility in practice. And that's one of the things that make us so proud about Gary, among other things, such as the light he brings to his leadership within medicine. And I think this case really reflects the humility that he practices. So huge round of applause virtually for all the recipients of our Clinical Decision Making Award, Maria, Jack, Baloo, and Gary. Thank you so much, everyone.
Thank you all for being here. It's great to have all our chiefs here presenting these awards, and congratulations to those residents. I can tell you personally, working with them, some amazing clinicians on top of an amazing class. So congratulations. I want to turn over next to Dr. Hosamani, Poonam Hosamani, who's our Associate Program Director for the Internal Medicine Residency Program. She's going to introduce our speakers who will be talking about the Story of Stanford HEARs program. So great to have everybody. Dr. Hosamani, thank you for introducing. Turn it over to you.
Of course. Thank you so much, everyone. And thank you for being here. This is a really special day for all of us in the residency program leadership to be able to celebrate so many of our residents' accomplishments. And we are really excited to hear about this particular one that we'll talk about this morning. So I have the distinct honor of introducing our speakers for today, who are a wonderful group of incredible women in medicine who have so much to talk about and tell you about that they've been working on behind the scenes. So Dr. Christine Santiago is our first speaker today. She's a graduate of Harvard Medical School, received her MPH from Berkeley. She matched into our internal medicine residency program in 2019 and served as chief resident this last year. We are incredibly proud of Dr. Santiago's work in health equity and addressing healthcare disparities for vulnerable populations. Her leadership has been instrumental in the work you'll hear about, and we are so honored to say that Dr. Santiago will be joining the Division of Hospital Medicine in just a few weeks. Dr. Gabriela Spencer Bonilla is a graduate of the University of Puerto Rico Medical School and received her master's in clinical and translational science from Mayo. Dr. Spencer Bonilla is a graduate of our internal medicine residency program and served as a chief resident from 2021 to 2022. We are so incredibly proud of Dr. Spencer Bonilla's and her efforts in creating health equity curricula for our residents during her time in residency, as well as her extensive research work in cardiology. And we were so honored that Dr. Spencer Bonilla matched into our cardiology fellowship program, where she is currently finishing up her first year. Dr. Natasha Steele graduated from the University of Washington School of Medicine, received her MPH from George Washington University School of Public Health. We were delighted when Dr. Steele matched with us in 2020, and her time at Stanford has been spent doing incredible work in cancer survivorship and sharing her own powerful story. She is the winner of the first honorary Brooke Gabster Award for Patient Care, and we are so honored that Dr. Steele is joining us in the Division of Hospital Medicine this fall. Dr. Emily Woods is a graduate of Emory University School of Medicine, where she also received her PhD in microbiology and medical genetics. We were honored when she matched with us in 2020, and during her time at Stanford, she's been recognized for her outstanding clinical skills, being recognized with the Wolfson Award, and doing research on health disparities, particularly as it relates to infectious disease. She'll be joining Dr. Matt Boggio's lab after graduation and working on molecular diagnostics and ID. They're here to talk to you about some resident-led initiatives, which we are so incredibly proud of, that come out of our residency program year after year. And I would love to hand it over to this fantastic group of women.
Thank you so much, Dr. Hosamani, and thank you everyone for joining us for Grand Rounds. As Dr. Hosamani shared, I've been here since 2018 when I was a resident in the IM program, and where I had the pleasure to work with Christine, Emily, and Natasha. And my colleagues and I will be telling you the story about this program that we hold near and dear to our hearts. And we really look forward to a conversation with you all at the end of this presentation. I'll give you just a snapshot of what the HEARs program is to begin with, and then we'll kind of get into the story. But the HEARs program originated in 2020, and it stands for the Stanford Health Equity Advocacy and Research Program. and it's a training track within the Stanford IM residency. The objective is to help trainees who really want to dedicate their careers to health equity and health justice. And it prepares residents to become leaders that will basically change the way that medicine is practiced and push forward health justice and advocate for local underserved patients. In this presentation, I'll tell you a little bit about the origin story of Stanford HEARs. Christine will give you some insight into how we created the Stanford HEARs program. We'll share some of the amazing resident initiatives that have come out of this program. And finally, we'll end with some insight into what we have learned thus far and an invitation for collaboration. When Christine and I were early in our residency training program, we found each other and we had a lot of conversations about what we wanted to focus on and learn during residency. Like I'm sure many of you out there, the reason why we became physicians or why we worked to become physicians was really to address health inequity. We were really eager to learn about physiology, guideline-based medicine, all the clinical expertise at Stanford. But for us, being excellent doctors meant advocating for the health of our communities and advocating for health justice and serving marginalized communities. Some suggested that perhaps we should wait to start this work until after residency, but we felt like that was a waste of time when the work is so urgently needed. And we really felt that we couldn't wait. It really was what made us tick and what made our training meaningful. Christine and I both came from about 3,000 miles away from Stanford. I'm from Puerto Rico, and Christine came from New York by way of Boston. And as you all know, both New York and Puerto Rico have garnered national attention for how health crises disproportionately affect marginalized folks. So that was always present in how we thought about medicine and how we thought about our futures. When we got to the Bay Area, we noticed a lot less conversation about how health equity and race affect the health of our patients. But we know that the Bay Area is not exempt from this. Just across the bridge in the East Bay, a child born in downtown Oakland can expect to live 11 years less than one born in Walnut Creek, just one BART stop away. And the parents of that child in Oakland can expect many more ER visits than in other parts of the East Bay. But what about Santa Clara County, where we practice? We are next to the wealthiest zip code in the country. There's a huge issue with health inequality in this area. These data were collected from 2005 to 2009, but there hasn't really been significant change since then. On this map, you can see the census tract with the highest poverty levels in brown and yellow. In, for example, Los Altos, poverty levels, or Los Altos, Cupertino, and Sunnyvale, fewer than 7% of families live under the federal poverty level, and those are the areas in dark and light green. But if you look at the areas in brown and yellow, which is mostly East Santa Clara and East San Jose, upwards of 12% of families and up to 1/3 of families are living in poverty. Similarly, on the map on the right, you can see the census tracts with the highest life expectancy in dark blue, and those with the lowest life expectancy in pink and light blue. The areas with the lowest life expectancy can expect to live about 10 to 20 fewer years than the areas in dark blue. Unsurprisingly, there's a huge amount of overlap with the white and pink on the right and the brown and yellow on the left. I don't know if you can raise hands on this Zoom, but by Zoom raise of hands, how many of you have received this message? An inbox message telling you that your patient is not going to be able to receive the care they need because their insurance isn't contracted with the specialty that you need them to see. These are our patients. This is what we see every day, and insurance continues to be an issue, though it's improving. In 2009, about 30 to 40% of Black and Latinx folks were uninsured, compared to greater than 85% of Asian Pacific Islander and white patients. So this is extremely relevant to us, and this is what we deal with every day, and I'm sure anyone that's in the clinical setting can relate. While Christine and I were thinking about this and thinking about how we can make our training align with what we were seeing, the world also started paying attention. In the midst of these conversations, we started to see the headlines. Black and brown folks were more likely to die and get COVID. Black and brown folks were less likely to get the right care at the right time. The long-standing racial disparities and structural violence that marginalized communities have been dealing with for centuries were finally center stage. And we saw it replicated around the country and with emerging diseases. For us, there was a sense of relief that the country was finally paying attention, but there was also a sense of anguish. How is anyone surprised? Why is this being sensationalized? Christine, Emily, Natasha, and I all spent a significant amount of our training caring for patients during the pandemic. Each of those additional and preventable deaths to us have a face, a family, and a story. For my part, I'm still processing and devastating for the amount of phone calls I made, mostly in Spanish, from the ICU to tell families that their loved one had died. We have signed in our training more death certificates than many physicians will in their careers. And for many of these, after, we consoled grieving sons, daughters, spouses, grandchildren with the heaviness of knowing that the death was really a preventable injustice. Of course, when the data on death was quantified, there was no surprise. Black and Latinx families were more likely to lose their loved ones to COVID. Latinx folks make up 1/4 of the population in Santa Clara, but accounted for almost 1/3 of the deaths. And if you stratify by poverty level, we'll get predictable results again. Each of these deaths created voids, craters, and suffering that will take generations to heal. And as you all remember, 2020 was a year of great suffering overall. With the number of tragic stories that we hear every day, I think it could be easy for me to move quickly through this slide, but we really want to take a moment to remember where we were and to remember the lives that were lost. But in 2020, everything kind of came to a head. As you remember, in 2014, Eric Garner, a 43-year-old Black man, was killed by homicide by the New York Police Department for selling cigarettes. That same year, Tamir Rice, a 12-year-old boy, was murdered by a police officer in Cleveland, Ohio, while playing outside with a toy gun. In 2015, Samuel DeBose, a 43-year-old Black man, was murdered by police officers for not having a front license plate. In February of 2020, Ahmaud Arbery, a 25-year-old Black man, was murdered while jogging. Just a month later, Breonna Taylor, a 26-year-old Black woman, was murdered in Louisville, Kentucky, in her own home. And in May of 2020, while the world was grappling with the beginnings of the COVID pandemic, George Floyd's murder was broadcast across the country. The threats to our brothers and sisters were palpable, and they were harrowing. I, for one, wished my dad would never have to leave his home so he wouldn't be in danger by COVID or by violence. And the intersection between state violence and health disparities was glaring. With the compounding news of state violence against Black people and the disparities in illness and death due to COVID, the medical community responded with a lot of energy. Numerous thought pieces were published by leaders in the medical community. Medical societies came together to issue statements calling attention to the fact that it was structural racism and not race that was fundamental in the driving of health disparities. As you all remember, Stanford became a national leader in this area. There were pilot projects funded on the effects of telehealth, the relationships between food insecurity and COVID, among other crucial topics to move the field forward. And that really happened globally. This is a result of a PubMed search looking for disparities and mentioned in any article. And you can see there was a huge jump from 2019 to 2020. We saw the Stanford community mobilize in a way we had never seen before. And through that coming together in the suffering, there was hope and there was purpose. Christine and I found support in each other, in our conversations. And with all of that energy, we wanted to get to work. And Christine will tell you just how we did that.
Thank you so much, Gabby. Just listening to Gabby describe all the health disparities that we already knew existed before COVID, and then were exacerbated by the pandemic, even now makes me feel, as I'm sure many of you feel, overwhelmed and helpless. How can we as physicians make a dent in these disparities when we know that at least part of them are structural and can be difficult to dismantle? These were the feelings and sentiments Gabby and I were grappling with during our training. And instead of dismissing them, ignoring them, or focusing on what we couldn't achieve, we instead thought about how can we empower and train ourselves to become better physician advocates to champion health equity for all our patients. And this was how Stanford HEARs was formed. I remember at the time thinking, how wonderful would it be if we could have a training program that could equip physicians who are passionate about health equity with the tools and skills to address some of these disparities. What would that look like? Who would need to be involved? And after conversations with Gabby, the first people we turned to with our lofty ideas for a training program were these folks here, Wendy, Poonam, and Mabel, as they were our personal mentors, associate program directors, and expert educators at Stanford and the VA. These three faculty were instrumental for helping us think through the feasibility of the program, how it could fit into predefined structures of our residency, and recommended that we look at other models of training programs outside of Stanford. And so we did. In 2019 and early 2020, we saw many models for health equity training programs based in primary care or outside of internal medicine like pediatrics. We also found that within internal medicine, there were many tracks dedicated to global health, but at that time, there were very limited options for residency training programs in internal medicine focused on local vulnerable patient populations. So at this point, it seemed like there was a need. And while Gabby and I knew how crucial this work was for us, we did not yet know whether other residents in our program felt similarly. And so in 2020, we sent out a survey to the internal medicine residency program, asking our senior residents this very question. And 13% of our senior residents expressed an interest in a career working with underserved patients and completed the survey. And next, I'll share with you some of the results. So 87% of the respondents felt like incorporating training for vulnerable patients into the internal medicine residency program was very important. And 67% said that they would be interested in participating in a health equity training program. Gabby and I at the time felt very ill-equipped to provide the highest level of care for our vulnerable patients. And so we asked our residents a similar question. How comfortable do you feel caring for vulnerable patients? And only 7% of the respondents felt very comfortable caring for vulnerable patients. 54% were either uncomfortable or neutral about the care they were providing. If we were going to create a new health equity training program, we wanted it to be tailored to the residents and fill in the knowledge gaps that existed in the current training structure. When we asked the residents what they wanted to learn more about in caring for local underserved patients, our residents responded and said that they wanted to learn about the barriers with access to care, what the best approaches were to providing culturally sensitive care. They wanted to learn more about the resources they should be providing their patients, and they wanted more rotations geared towards working with underserved patient populations. Lastly, they wanted the skills to problem solve within a broken medical system and societal structure. Invigorated by the shared interest from our fellow residents and armed with the information from our survey about what residents would want, we then set out to create our very own unique resident-created and driven health equity program. Next, we set out to come up with a name for our program and define our mission. Funny enough, reflecting back, I remember one of the hardest parts of creating this program was actually not leadership buy-in or the resident interest. It was actually something seemingly as small as coming up with a name and an acronym that was memorable and represented the mission of our program. I remember at the time roping everyone in, including my father-in-law, helping with the brainstorm. Gabby and I narrowed down the list, and then we voted with our faculty members on a name. You might be surprised that it was not Stanford HEARs, but Stanford HEALs that won the vote. However, we found out that UCSF has a global health track called UCSF HEALs, And since that name was already claimed, Stanford HEARs became the acronym for our program. So what is Stanford HEARs? It's the Health Equity Advocacy and Research Program. It's a program within the internal medicine residency that aims to train the future physician leaders who will promote health equity in our local underserved communities. One very unique and intentional aspect of our program is that it was created by residents for residents. Gabby and I really wanted this initiative to be sustainable and relevant in years to come, knowing that the faces of our vulnerable patients will change over time, and the types of health disparities will as well. So allowing our residents to drive their own training and providing the flexibility to change the program was what Gabby and I felt would keep this program relevant and alive with the changing passions of each generation of physicians to come. By using the needs assessment survey, best practices from other equity programs in primary care and pediatrics, and what we felt were important skills for our residents working in this space, we came up with 4 main objectives for this program, which were clinical exposure, faculty mentorship, scholarly work, and the development of advocacy skills. We then translated those objectives into the core requirements of the program. For the clinical exposure part, all HEARs residents would participate in a core rotation that broadly exposes them to working with and caring for underserved patients from different communities. The social medicine rotation is a collaboration with the Santa Clara Valley Medical Center located in West San Jose, which cares for a broad, diverse set of vulnerable patients. And then the VA-based rotation cares for vets that are dealing with homelessness. For our electives, we really wanted residents to have the flexibility to pick patient populations they wanted to learn more about and gain skills working with. So we have the addiction medicine rotation at Stanford, learning alongside our psychiatry colleagues, the women's health clinic, and then some more rotations at Santa Clara Valley Medical Center. The Fair Oaks Clinic is a federally qualified health center that takes care of all patients regardless of their immigration status. And lastly, they can apply for the Johnson & Johnson Shiprock rotation in New Mexico, working at the Northern Navajo Medical Center. We match all residents with a faculty mentor. Gabby and I really benefited from the mentorship we received in creating this program and wanted to ensure that other residents could also continue to grow in their career and leadership trajectories by learning from faculty. Lastly, every resident is required to do some scholarly work, which is really aimed at developing residents' leadership and advocacy skills. And since our residents are going into many different fields of practice, we wanted to leave the type of scholarly work open to their passions and their interests. So residents can work on quality improvement related work. They can participate in the Stanford Leadership, Education, and Advancing Diversity program, also called LEAD, that would meet their scholarly requirement. They can work on research and health disparities, develop teaching curriculums around health equity, and we really encourage them to create and expand the clinical rotations offered for different patient populations. In 2020, we piloted the program, Gabby and I and Mayuri, who's a fellow resident colleague of ours. So we started out pretty small, you can see in 2020. Since the pilot, the interest in our program has continued to grow. And we are thrilled to welcome our largest class of Stanford HEARs residents yet. In 2023, we will have 12 internal medicine residents. Since the pilot, Gabby has completed her chief year and is now in cardiology fellowship. I am currently at the end of my chief year, but throughout this year, we've been working very closely with our current resident leadership in expanding the resident involvement and working on new rotations for Stanford HEARs. These are the 3 phenomenal Stanford HEARs resident leaders for this year, Natasha, Emily, and Nancy. It has been such an inspiration and an honor to work alongside them this year. And now Natasha and Emily will share the current resident initiatives and new rotations that we have been working on.
Great. So as Christine mentioned, Natasha and I will now be talking a little bit more about the current work that's going on within HEARs. One of the main projects that we as the resident leaders for the HEARs program have been working on this year is the creation of a HEARs capstone course. The idea for this course was born last spring when Nancy, Natasha, and I were working together on nights at the VA. In between new admits and e-teams, we found ourselves dreaming big about how to make residency, medicine, and our communities better. And at that point in the year, we already knew that we'd be coming on as the HEARs leaders for the following year. So inevitably, these thoughts that we were having quickly morphed into ideas for what we could do with the HEARs program. We thought about ways to incorporate more advocacy training into the program, ways to increase connections with the community, ways to build solidarity amongst residents who care about these issues, ways to expose residents to different career paths, and ways to support residents in their scholarly work. From these many ideas, we started to distill down some key concepts into a plan to create an elective course for the HEARs residents. Over the following weeks, we reached out to the HEARs faculty with our general idea for a course, and we were happily greeted with a lot of support. Dr. Caceres had already been working on designing a more clinically focused HEARs elective, and so we were able to build on some of her momentum as we started to craft our own syllabus. We also surveyed the other HEARs residents to learn what topics and types of activities that they would find most useful. Our goal was to create a rotation that would address these resident-identified needs and tie together the key components of the HEARs program. We wanted didactics that were focused on different vulnerable populations, mentorship, community connections, and development of advocacy skills. So I'll go through each of these components in a little bit more detail in just a second, but first, just a couple details about the program. It is now considered a core component of the HEARs curriculum. It's a 2-week elective course, and we actually just started this week, so we're really excited to see how it plays out over the next couple weeks. And then this year, all 7 of the current HEARs residents are taking the course. And we're so grateful for our program administrators for working with us to shuffle around people's schedules to actually make this a reality for all of the residents to be on together. And we're also indebted to Dr. Caceres and Christine for being our wonderful course facilitators this year. So now going into a couple details of the course. For the didactic portion, we have 16 sessions that are primarily focused on best practices for caring for diverse, vulnerable populations. We invited speakers from Stanford, Santa Clara Valley, some community organizations, and even nationally, with expertise in the areas of need that were identified in our survey of current HEARs residents. So just to give a few examples of some of the topics that will be covered, we have talks entitled Rounding While Black, LGBTQ sexual health, case studies on climate change and health, prison medicine, language barriers, the problems they can cause and how to solve them. And this is really just a small selection of the wide breadth of topics that we'll be covering. 2 other components that we wanted to incorporate were career development and building community connections. So we have 2 panels that are designed to expose residents to different career paths. One panel is composed of our HEARs faculty leaders, and one panel is composed of several of the leaders within the DEI space at Stanford. And we've also arranged for 2 community site visits, one to the Opportunity Center here in Palo Alto that focuses on providing multidisciplinary care for people who are experiencing homelessness. And then we also have one to the San Jose Reentry Center, which is focused on providing resources for people who are reentering into society after having been incarcerated. And the goal of these visits is to help our residents learn about different resources that are available in our community, learn about the different populations that are served by these sites, and to start to build some connections. And then the last major of the course focuses on advocacy and scholarly work. Until now, the HEARs curriculum has not included much formal exposure to advocacy skills, because it's always been really hard to coordinate all of the residents' disparate schedules to organize a speaker or workshop that enough people were actually able to attend. So it was really important for us to incorporate a lot of advocacy training into this course. And so to that end, we have several skills workshops, including ones on medical education as advocacy, advocacy through legislation, and persuasive writing of op-eds. And our goal is for residents to not only learn skills through these workshops, but to also have tangible work that they create using these skills. For example, we intend for all of the residents to write a publishable op-ed by the end of the course. Let me just skip this for a second time. Sure, yeah.
Okay, hi everyone.
I will go back super quickly. I think Emily just gave a really amazing overview of what we're offering our specific HEARs residents. But we also just wanted to make the point that we have the STAN lectureship series. This was actually started by one of our former chief residents, but the HEARs program has absorbed it. And this is really for all residents to really appreciate and learn about these issues and have a chance to network with leaders in their communities. So as you saw earlier, a scholarly work and applying the rigor of academic methods to our approach to community health and equity is really at the core of what we do at HEARs. And we wanted to pause and really highlight the work of our residents. We believe that, to really train the next leaders of clinicians and researchers in health equity, we really have to have these projects, these mentorship, these collaborations, and just excited to share them with you. So first up, Gabby, who you heard from earlier, had this incredible project with KP and our own Dr. Ronald Ratellis, looking at racial and ethnic disparities in transthyretin as it relates to cardiac amyloid. Caitlin Palmer-Chow, one of our residents who has a particular interest in language disparities, did this incredible project to really incorporate interpreters both into the GME and intern within internal medicine orientations and really make sure that there's a curriculum to train our residents how to work with interpreters so that our patients who speak different languages get the same level of care. Again, Gabby was looking at statin use in older adults, being a cardiology research fellow and looking at how this plays out within ethnic disparities. Christine Santiago looked here at Stanford at bed use and how bed allocation is related to ethnic disparities and how that affects our population. Emily, who you just heard from, was the winner of our medicine research symposium this year, looking at factors associated with COVID-19 outbreaks at detention centers, and actually found that within privatized detention centers for COVID-19, the outbreaks were much more frequent and severe. You might remember Mayuri Chandran and Dr. Kevin Schulman's talk last year looking at scarcity as it relates to utilities, so things like water and electricity and how that plays out in different ethnic and minority populations. A lot of our work focuses on how we address the disparate needs of our community members as it relates to marginalized groups, but at HEARs, we're also really focused on how do we train a diverse physician workforce. This was a talk I gave at the AAMC looking at ableism in medicine and how do we recruit, train, and retain physicians with diverse illness experiences and make sure that our workforce really reflects the people that we care for. And then last but not least, Christine had mentioned before our Stanford LEAD program. This is a 10-month longitudinal leadership program, both for residents and fellows across Stanford Medicine and GME. And it's really very specific, targeted for the development of leadership and scholarship skills that are really meant to address issues related to diversity, equity, and inclusion, and to produce leaders in academic medicine. And I was fortunate to be one of the lead scholars this year. And here I am with my colleagues presenting a workshop that we did that was very interactive based on how to train clinicians in the needs of refugee and immigrant health populations. So these are just some examples of how much we've really focused on taking the rigor of academic methods and translating it into our initiatives, our community partnerships, and our research efforts. And then, okay, Christine's telling me to skip over this, but I think it's important because this is a new position, this health equity champion that Nancy and Christine are involved in from a QI perspective. So quickly, just getting through the next point around our advocacy efforts. This is something that we were really passionate about when this curriculum started, that we'd have this component of advocacy. And EGFR and the race correction is just one example of how we've united as a group to create change both here at Stanford and nationally. So many of you who practice clinical medicine will remember a time where we had race corrections for calculating kidney function in our patient populations. And these were really very binary, so Black versus not Black. And as we all know, binary construct of race is an illusion, as is race itself. And so I remember being at University of Washington. I graduated in 2020, and there were conversations around race-based tools in clinical medicine and how they were perpetuating systems of inequity. And UW was one of the first health institutions to eliminate the EGFR. When I got to Stanford, around the same time, the National Kidney Foundation, the American Society of Nephrologists had convened a task force. This was 2021. they were looking at race in clinical practice, and they published in New England Journal and really modified the equation and said, listen, race is disproportionately, using race as a qualifier is disproportionately impacting marginalized communities in terms of their candidacy for transplant, in terms of their medication dosing, in terms of diagnosing CKD. So me, along with KP and Casey Wren, we said, what can we do about this? How can we create change here at Stanford? So we approached our colleagues in the Department of Nephrology, Glenn Chertow, who was chair at the time, as well as Tara Chang, and said, we're thinking about this, guys. How can we think about this together? And they were just tremendous allies. They were incredibly excited. They invited us to give grand rounds, which as a non-nephrologist was likely one of the scariest things I've ever done, sort of talking to a nephrologist about kidney function. They put us on a task force, and Stanford Medicine now uses a modified equation without race, as well as cystatin C. I believe we were one of the first institutions in the country to implement cystatin C clinically. So this was just such an incredible example of how our enthusiasm and our noticing certain things was met by equal enthusiasm by our leadership here at Stanford, and we were able to create change for our patients on an institutional level, and it was just a total joy to be a part of. Briefly, because I know we're sort of running short on time, Gabby, who you heard from earlier, was really sort of enthusiastic about making sure there were equal opportunities for cardiology research and clinical fellows to rotate in clinical longitudinal environments that serve these patient populations. So the federally qualified health center, Fair Oaks, is now one of our sites for continuity care for cardiology for our fellowship program, thanks to Gabby reaching out to our faculty there, Jacqueline Sharabati and Richard Elling. And so, these are just some examples of research and advocacy that we've been able to create through this program with our incredible faculty leadership and support from our larger internal medicine program. And it's been such a privilege to be a part of this community. I'm going to hand it back over to Christine for final thoughts and future directions.
Thank you so much, Emily and Natasha, for sharing the work of our amazing work of our residents. So where do we go from here? Our dream is for this training program to continue to grow through expansion of new rotations, such as collaborations with the LGBTQ clinic and re-entry medicine rotations. We hope to expand our faculty mentors who are doing amazing work in health equities, and further our collaborations with our community partners to create sustainable relationships in our local communities. I want to leave you all with some lessons we learned in creating this program and working with our vulnerable patients. We learned that no one is exempt. There is no part of this country, even one of the wealthiest, such as Palo Alto, that does not have issues with health equity and disparities. COVID taught us that even if you are not measuring disparities, in no way does that mean that they do not exist. We cannot afford to wait for another pandemic to address health disparities. Let the lives lost from preventable deaths during this tragic pandemic not be in vain. We learned that we are stronger together. We can make change through small incremental steps. With the same energy that brought us together in 2020, let's continue to work together as individuals and as an organization to ensure that these tragedies do not repeat themselves in the future. And lastly, we learned it takes a village. A program such as this could not occur without the unwavering support of the internal medicine residency program led by Ron Wutullis and the associate program directors, to Audrey and our administrative team for bending over backwards to ensure that our residents could take part in their capstone rotation. We thank you. To our community partners, Jonathan Shaw and Alex, you have provided such amazing information about resources and sustainable ideas to incorporate the community into our program. And lastly, we want to thank all our faculty who have taken the time to mentor our residents. I'm excited to continue this work as I transition from my role as chief resident to a new faculty in the Division of Hospital Medicine. And I cannot wait for the next set of passionate residents to come through and inspire us all. We want to thank all of you for listening to our talk and invite you to reach out to us via email, Twitter, or looking up our website. We would love to collaborate and work together with you in building a Stanford healthcare system that is equitable for all our patients. Thank you.
Thank you, Dr. Santiago, and for all of the doctors for presenting. This is such a great example of the unique and amazing things that our faculty and our upcoming faculty, and certainly our house staff, our residents do here. Thank you for being here to present today and really show all the work that you've been doing. And a lot of us have heard about IM HEARs a lot for years, but to have more detailed discussion of the things that you're doing and how it started was really, really insightful. I want to just do a quick call. I see a couple of questions are coming out now. If I have time, I'd love to ask questions too, but we already have questions coming here. Dr. Dunn has a comment or question as well. Maybe I'll turn it to you first, Dr. Dunn. Thanks.
Sure. I'll start with a comment just because I am absolutely blown away at this group. I have certainly heard about IM HEARs, but to hear some of the details and the boldness that you all had in putting this program together and then scaling it the way you have, I'm so excited that there are 12 residents that are going to be participating. And then the capstone curriculum is really just fantastic. I think that you all truly are affecting change. And I love that you did this, it's by residents for residents. And certainly as I came through this residency, I had no idea how to have this sort of path, even though my passions are certainly in line with yours. And I just want to tip my hat to you all. This is an amazing program. And I see that you are really going to make a difference. And it gives me such hope for tomorrow, the future. So congratulations. And I'd love to just hear more about scaling, to be honest. I see you've had a partnership with Cardiovascular fellows, obviously, but are there any plans to have this, to be able to scale this to other internal medicine fellowship programs, or even scaling it on a larger scale?
Yeah, thank you so much for that question. I think part of the reason we really wanted to give this talk was that we really wanted to grow this first here within Stanford. And so really want to invite all of you to partner with us for those that really want to collaborate to be our faculty mentors. We really want to scale and grow that way. And it's hard to do without having everybody involved. As I said, it really does take a village. There's so many different ways to get involved, whether that's through research or QI as a faculty. In addition to that, we want to scale it with the rotations that we're offering. And so, if you are a community site or another location, we really do want to think about having a larger amount of the residents that are participating in our program be able to have a broader exposure. And then really great question about how can we expand this outside of to just Stanford. I know that in the internal medicine department, there's been, I know the palliative care group has reached out to us, and we've had medical students that have actually reached out. We want to make this also a pipeline, so not just for our residents, but kind of starting early. How can we get into our high schools? How can we get into our communities and really play a role early? And so those are some of the ideas we have, but I'll let our panelists
Jonathan too, being our new faculty advisor.
Yeah, I mean, I think we've all been, we're really, really grateful to Jonathan Shaw. I hope he's logged in because he's been an instrumental support faculty member. And I think kind of the birth of the community engagement associate chair position at the same time as HEARs has been a really kind of synergistic relationship. So I think it'll be a great way to get farther into the community. And I know that there's other faculty or fellowship programs that are also interested in having an opportunity like we have at Fair Oaks right now for their trainees to be more involved. So I think this is the whole point of this presentation, is this conversation and learning from all of you that are here with us about how we can make this grow and continue to make a positive impact in surrounding community.
Thank you for that question, Dr. Dunn, and thank you all. I have a couple questions here. One on a similar thread, Dr. Cleaver asked, does the IM HEARs have interactions with other schools that have equity interests, such as education or law? Is that something that might be down the line?
If there's anyone on that wants to be a community partner, I think that one thing that is really exciting is this advocacy course that they're having in the capstone course, and I think that that expertise isn't so clearly inside of medicine, and it would be great to have people in law or policy also be contributing?
Yeah, and some of our guest lecturers are coming actually specifically from other departments here at Stanford to help train us on how to write op-eds, people who write for the New York Times and things like that. So we're trying to be as interdisciplinary as possible.
Yeah, Glenn Cramon, for those that may know him, the New York Times. I think he's been with the New York Times as an editorial for the past 20 years. He's also in the business school, is actually coming to not only help us think through op-eds, but review our op-eds and really help with that aspect. So, you know, we also have Samantha Wong locally here, who has done a lot of work around education and using education as a tool for thinking through health equity. And so we also have that, but we are, as I said, always looking for more speakers for our course and looking to grow the legal side as well as on the education side. Lastly, you know, we're also looking for policy too. So we do have we have the California Medical Association will be giving a talk to us about how can we advocate from the policy side. So really looking at all different lens is what we'd love to work and collaborate with you.
Mm-hmm.
Excellent.
And I will say, you know, we've tried to be as interdisciplinary as possible within Stanford, but we're also doing this within our community partnerships. Last year, we had a project with the Department of Public Defense, you know, folks that represent some of our most vulnerable members of our community, advocating to get attorneys into our health centers that were serving the same population so they could do sort of wraparound care. So we were part of facilitating a collaboration between the attorneys and the community-based physicians and making sure they were kind of working together to serve these clients at the same time. So that was kind of exciting to be a part of on the community front.
Excellent. I have a question here. I might try to get to one more question if we can, and I'm going to mention something for comments and close with Dr. Harrington. But the most voted here one is, thank you for the great work. Amazing. It was mentioned that only 7% of residents felt comfortable taking care of vulnerable population. What were their concerns in taking care of that vulnerable population?
Yeah, I think that's a really good question. You know, how we sent out, I will say 7% felt very comfortable. So it was kind of a scalar. So I would say like 54% were either neutral or felt uncomfortable. So, you know, I would say like, just to clarify that it was very comfortable. But I will say, you know, one downside about it was that it was a survey that didn't allow for, at least that part didn't allow for further information for residents to kind of to put information about. But I will say, at least on my end, from, you know, for working with me and Gabby, some of the things we felt very uncomfortable. We didn't feel like we could provide the highest level of care is, you know, we didn't really know what the resources were. We weren't working with those populations very frequently at Stanford, you know, and that's really changed over time as Stanford has continued to grow. We've seen a lot more diverse patients that we're working with. But I think those are probably a couple of the things, you know, and Gabby, feel free to weigh in.
Yeah, I remember us having these conversations at the beginning. And one thing that was really prominent at the beginning of the pandemic was, of course, people that were unhoused were really frequently being admitted to the hospital. And I remember in conversation with people that were interested in HEARs, there was this huge frustration about discharging people to the street and not having the right support for them after they left the hospital. And I remember that the residents really wanted a list of resources that, and this was also, I think, when we were having a huge shortage with social work in the inpatient side. As you know, residents are mostly on the inpatient side. But I remember that being one of the biggest issues that people felt uncomfortable with. When we say that the only option is for someone to discharge to the street, what does that mean and what happens to them next? And I think that's a problem that's still unresolved and where we could use more collaboration and help.
Excellent. Maybe I can get one more quick question here. Dr. Barry had asked, she says, amazing program. Thank you. Will you follow up on your graduate career pathways, perhaps to demonstrate impact and serve as role models?
Yeah, that's something that we plan to do. Right now, you know, we only have, I guess, 1 or 2, 3 or 4 graduates, but as you can see, this is continuing to grow. So far, we're collecting all of the emails and communication with our residents that have left Stanford or those that are staying on. And the hope is to see the long-term impact of this, not just the short-term of the scholarly work that they're producing, but long-term, you know, are residents really working with our underserved communities? Are they really continuing this mission forward? And then also to leverage our alumni in the future is something that we really hope to do as our faculty, to leverage them in wherever they might be, whether that's in policy, whether they stay in healthcare field, and use them as mentors to our new residents as well. So yes, we're hoping to figure out where people go in the future.
Excellent. I have a few comments here I wanted to highlight. Dr. Shah, by the way, you mentioned him earlier. He's actually in clinic right now. Maybe was seeing a patient. He wanted to comment, but he says congratulations and just a lot of great comments on the amazing work you've done. Doctors Winslow, Doctors Kim are all saying how wonderful work. You have a lot of division chiefs here. Dr. Lewis, of course, saying amazing work. Dr. Chang is also saying congratulations. Dr. Kim has mentioned he'd be happy to recruit any of you to help do more work continuing on there. So that's great to see as well. Thanks, Ray, and Caceres, Dr. Caceres as well. So I think it's a new record for the number of positive and thanking comments here for Grand Rounds. And I just want also, Dr. Santiago, we're just so excited to have you joining us at the Division of Hospital Medicine. So we couldn't be more excited for that. So we're looking forward to having you join us very, very soon.
And Dr. Steele as well.
Oh yes, and thank you as well. Well, we're so excited. I saw you looking. We're so excited to be recruiting and continuing this work in our division and really throughout the whole department. So we had a lot of great questions about the future of this, which is really a great sign. I want to end and turn over to Dr. Harrington. Dr. Harrington, thanks for closing us out today.
So thank you, Errol. And first off, I wanted to say how honored I am to have this program in the Department of Medicine. This is extraordinary work. It's rare that something crosses all four of our missions, delivering excellent clinical care, particularly to those who are most vulnerable and most needy, delivering great education and trying to train the next group of people to follow in this work, doing research to try to really quantify what you're observing and how we might make a difference. And then you've noted several times community partnerships. So I want to not just congratulate you, but thank you. It's rare that all four missions come together in such a wonderful way. And finally, we talk all the time in science about having impact. You've demonstrated how you have impact. You take great clinical observations, you combine it with research to influence advocacy and policy. And when you change the way policy is done, you have impact. And so kudos to all of you and the larger group that have been working with you. I just think this is an amazing demonstration of what's possible when you bring incredibly talented people here to campus. So kudos to all of you and thank you for what you're doing. Errol, you're on mute.
I thought I clicked it. Thanks. Thank you, Dr. Harrington, for closing us out. And thank you, everybody, for that presentation and for being here. Have a great rest of the week, and we'll see you next week. Thank you. Bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.